Dr. Swaraj, before we start the session, uh, I would like to say a few words about the LOC and the Eizoc, right? So what the LOC and OSWB has done, I'm full of gratitude. Eizoc is full of gratitude. Probably for the first time in the history of AIOS, we have been given such a space, a commanding space. Rather, you all have put us on the national frame. So it was so visible. So we are really indebted to you all. We are also indebted to the All India Ophthalmic Society for giving us a session. Probably this is also happening for the first time. So it is all first time which has happened, and we are all grateful to the OSWB, AIOS, and the LOC of the East. It's a marvelous effort, and I think it will further give us strength. The bonding is going to become strong, and we are going to put up a great show in future together. So with these words, over to you, Dr. Swaraj, to carry over with the scientific session. Yeah. So the first speaker of the session, we have Dr. Saraj Bhattacharya. For Eizoc purpose, he needs no introduction. He is from Assam. He is the General Secretary of East India Zonal Ophthalmic Congress, and he'll be talking on erratic, unpredictable people puzzle out of the situation. So over to you, Dr. Swaraj.
So good morning, everybody. My topic is erratic, unpredictable people puzzling out of the riddles. No financial interest, of course. The erratic behavior of the iris may be in the form of small pupil, iris prolapse, intraoperative floppy iris syndrome, reverse pupillary block, and iris lens diaphragm retropulsion syndrome.
1 second, can we call upon our president-elect of Eizoc? Doctor, please come to the dais. Jayanto Barua, sir.
The small pupil, how small? It may be 4 millimeter or less. 1.4% of all cases comes to this category. All steps of surgery becomes difficult. Now a small pupil, it may be an elastic or it may be rigid. Now, how to find the difference between the elastic pupil and the rigid pupil? See, this is an stretchable elastic pupil as if we see in case of IFS, whereas a rigid or fibrous pupil, which may be tearable or stretchable.
So we have Dr. Abhijit Ghosh also. Please take the chair, sir. Good morning and welcome.
Can I move the timer a little bit on the other side? Timer थोड़ा नीचे कर दिया ना? Yes.
Can I sit there? It's too cold here. Sorry, hi. Sorry, hi.
Yeah, it's coming now.
Sir,
Okay.
sir, I wanted to acknowledge Dr. Subhashis. Sir, I wanted to acknowledge Dr. Subhashis Nag also by calling him out. That's for few minutes only, sir. And after that, I'll call.
I will continue. The putting Visco or BSS.
Please, Subhashis.
In case of elastic people, there is a temporary expansion. As for example, in IFIS, in the rigid people, there is no expansion. As for example, in pseudo exfoliation. Now the management includes the preoperative NSAID drugs, intracameral adrenaline, viscodilatation, multiple sphincterotomies, and synecholysis, whereas iris management is done by iris retractor and the iris expander. The iris prolapse more likely to go out of the incision in cases where there is a lack of tone, as seen in the intraoperative floppy iris syndrome, an inadequately dilated pupil, a poorly constructed clear corneal incision, and a shallow anterior chamber. However, the reason is always a pressure gradient. Anytime the pressure behind the iris is more than the pressure in front of it, the iris will tend to prolapse out, and the treatment is always the same: neutralize the pressure gradient. And then the iris will return to its natural condition. Now, what is IFIS, Intraoperative Floppy Iris Syndrome? This was identified in 2004 and published in April 2005 by Dr. David Chang and John Campbell. Is specially associated with tamsulosin, the most commonly used drug for BPH, but has been reported to occur with other similar drugs too. And there is a tendency for the poor pupil dilatation. In addition, it has a ballowing of the flaccid iris trauma, progressive intraoperative pupil constriction, and propensity for the iris prolapse towards the phaco and the side port incision. The most commonly seen complications are iris trauma, posterior capsular tear, and vitreous loss. Now, why the Flomax? It relaxes the smooth muscles of the bladder, which is a mechanism of action for treating BPH. It acts on the iris dilator as well, by specifically targeting the alpha-1 receptor. The blockade of this receptor makes the conventional dilator drops ineffective. The floppy iris, the predisposing conditions are alpha-1 receptor antagonists like tamsulosin, terazosin, alphazosin, angiotensin antagonist, ETR antagonist, and nitrates, whereas in systemic diseases like chronic heart failure, diabetes, and systemic hypertension, no amount of history taking can prevent the surprise, but kept us alert and vigil during the procedure. The current concept, there is an inhibition of the iris dilator smooth muscle contraction leading to meiosis. There is a degeneration of the long-term dilator smooth muscle causing floppiness, and there is a strong affinity for some systemic medication like psychotropic drugs which binds to the iris pigment granules. It's important to know that even with the pupil diameter less than 7 millimeter, even with no history of intake of alpha-1 receptor blocker, IFS can happen. It can even happen after 1 year of stoppage, even after 3 to 4 days of starting of the therapy, and stopping doesn't help always. Even it may cause some hindrance in the form of urinary retention with the case of preoperative atropine use. The mechanical dilatation of the pupil is done by the pupil stretching, not effective in IFS as it is an elastic pupil, and controlled stretching before expanding as in case of a rigid pupil. Iris retractor and pupil expansion rings. In all these cases, it prevents it from constricting and restrain the iris from prolapsing. Now, I like to share a case where there is a 65-year-old patient, moderately dilated pupil, using tamsulosin for BPH. In this case, we are anticipating IFIS. In this situation, what we are doing, we are putting the iris hook, and taking extreme care, giving a long corneal tunnel. In all cases, this type of the trypan blue must be used. It's a pretty hard case, but very well managed. After putting the IOL, the iris hooks are carried out very comfortably. Then this is another case, 62 years BHP patient using medication with add-on pseudo exfoliation. Here in this case also, in the same type, we are doing paracentesis, putting the different number of iris hooks. Depending on the situation, 4 to 5, we can put it very comfortably, making the pupil in a very comfortable position, and rexis tunnel and so on. The iris hooks pearls are, while doing paracentesis, clear corneal, posteriorly directed, and iris hook introduction. I'm not going in all details of it. Now we'll come to the pupil expansion ring. Results are comparable with the iris retractor like Milligan ring. The surgeon must be trained to use the ring. Successful placement requires a narrow range of pupillary size and difficult to place if the anterior chamber is very shallow after the capsulotomy and hydrodissection. Now the present choice is the BHAX ring, where I'm just showing an example, 60 years old male using tamsulosin. We are anticipating IFIS in this case. Same way we are continuing after blue, then we are putting a BHAX expander, putting visco, and then the device is snugged into the anterior chamber with a 23 gauge forceps. The flanges are inserted below the iris, 3 flanges with the holes. And we continue with the surgery. After the IOL insertion, these are very comfortably removed out of the anterior chamber. I like to give an example of a small people where in this case what we are doing, we are trying to use all the maneuvers in the form of viscodilatation, then with the synecholysis, but it's not well helping us out. Then we are using a BHAX ring. Here we are using a BHAX forceps, specifically designed by one of our Eizoc member, Dr. Chauvin. Every one of us know him. And this similar way, the flanges with the holes are introduced one by one, and we end up with a beautiful hexagonal pupil. Next is the reverse pupillary block, the iris retropulsion syndrome, where this is in situation where the pushing the BSS with the cannula, the pupillary edge compresses against the lens, and there is a development of compartmental syndrome. The anterior chamber pressure increases, whereby the lens is pushed posteriorly. The situation where you can anticipate are high myope, post-vitrectomized eyes, and the young patient undergoing surgery. The pseudophakic reverse pupillary block may also occur in the patient with the pupillary optic capture in sulcus fixated IOL. There are clinical scenario being posterior displacement of the lens iris diaphragm, marked deepening of the anterior chamber, posterior iris bowing, pupil dilatation, and significant patient discomfort. And when it occurs 360 degree, we will call it lens iris diaphragm retropulsion syndrome. The reverse pupillary block are seen while doing hydrodissection during introduction of the irrigation ports and more with the use of viscoelastic Hilon 5, etc. Here, in this situation, this is a high myopic cases where we can see while putting the hydrodissection, the pupil is dilated. Once you touch it, the pupil return back to its normal position. And what are the take-home points? The iris may behave erratically at any point of surgery, but with adequate pre- and post-operative measures, it helps to manage the situation comfortably. Proper armamentarium must have backup IOL, iris expander, and CTR if the situation demands. And thank you for a patient hearing.
Thank you, Dr. Swaraj, for a very nice presentation. Just one quick question about the floppy iris syndrome. That means the take-home message is what you said, that history taking is very important, isn't it?
Yes.
And even if you take a history, you have a tamsulosin taking patient, stopping the tamsulosin is not going to help in the floppy iris syndrome. So you have to be prepared according to the history as to what can happen. So do you think you should put in the iris expanders or the pupil retractors in all cases of floppy iris syndrome?
In cases where once you put the visco, if you see the floppiness of the iris, a word of caution immediately comes up. Secondly, we should also, I have not added this, I have missed this line. We should do in a low fluidics. That is also very important. In the newer machines, they have been given a very nice in centurion, and all low fluidics very comfortably can be done.
And second point, what I feel is that the pump of the machine is probably also important in these kind of situations. You have a Venturi pump in which you have to stay at the center. All the pieces and everything comes to the center. You don't have to go to the periphery. Especially for these kind of cases, a Venturi pump is probably going to give you more comfort. This is what I have felt. So, can we move on to the second topic? Anybody, any panel, anyone asked to ask anybody?
Do you have any
Just
of using pediatric adrenaline?
Yeah. In the small people, always we give first viscodilation, followed by, before viscodilation also, we use it.
Because we also encounter so many such cases.
Yeah.
With my experiences, many a times like I can get away with adrenaline and viscodilation.
Intracameral adrenaline is more than enough in few of the cases. Here I am tried to show you the cases where there is, we have used the expanders and all other things.
I fully agree with you. Adrenaline do help a lot in tackling such cases. And I principally use, when I have some doubt, I always use adrenaline before surgery. And secondly, low parameters are there. And thirdly, make all the side ports very, very small, just enough for instruments to manipulate your instruments. And fourthly, use little higher IOP so that it presses the head. Thank you.
So we go with the second presentation.
Patient is hypertensive or a non-case of cardiac disease,
Nothing. Nothing happens. Nothing happens.
Intracameral doesn't make.
Doesn't give.
So can we go ahead with the second presentation, please, Dr. Swaraj?
Our second presentation is Fundal coloboma, an ode to the variety by Dr. Soni Sinha. She could not make it. Pratik will be helping us out. His son, Dr. Pratik. Her son, sorry.
So the presentation basically is by Dr. Soni Sinha only. It's a recorded.
Full volume for this presentation. So, good morning, ladies and gentlemen. Thank you, esteemed chair, and let us begin. Full volume, please. Okay.
The audio is from there.
Retinochoroidal colobomas, an ode to the variety. There are no financial interests. IC colobomas occur in 0.5 to 2.4 per 10,000 live births, either in isolation or with systemic abnormalities with varying phenotype. The embryonic fissure starts developing at the 4th week of gestation and closing at the 6th week from the equator. It gets completed at the 7th. The retina splits at the inner nuclear layer or the autoplexiform layer. The inner layers continue to form a thinned out intercalary membrane, while the outer layers curl up to fuse back with the RPE. The junction is called locus minoris resistentiae. The choroid terminates peripheral to the point of reversal, while the sclera is thinned and ectatic. OCT may show the transition zone as abrupt or gradual. The intracalary membrane may have cystic spaces, schisis or breaks. Vitreous attachment at the margin may be present with condensation. Intercalary membrane may also show hill-like projections into the vitreous cavity. Subclinical retinal detachments and intercalary membrane detachments can also be found. The colobomas may be either typical or atypical, complete or incomplete, or formifrosty or extreme with a cystic. The Eiderman classification is according to the extent and location of the coloboma, while the Lingam-Gopal classification takes into account the location of the disc, whether outside or within the coloboma, and the morphology of the disc, normal, abnormal, or independently colobomatous. These are some of the colobomas found in our institution. They may be associated with a number of genetic varieties and syndromes, which may be autosomal dominant, recessive, or both. It may be associated with hedgehog genes, PAX6 genes, PAX2 genes, PTPN11 gene, CHS10, or CHD7 gene. Any part of the body may be affected, including the brain, head, face, ears, neck, thorax, abdomen, skin, limbs, and the endocrine system. Secondary colobomas may be the result of drug intake by the mother due to nutritional deficiencies and other causes. The ocular associations may be in the lid and the lashes, the size of the eyeball, and can also be associated with axial myopia, cataract, motility problems, nystagmus, squint, leukocoria, glaucoma, and a non-detectable scotopic ERG. Associations may be bilateral or asymmetric. Amblyopia can occur due to refractive error, cataract, squint, dysphobia, dysgenesis, or other complications like lens dislocation. Rhegmatogenous RD has been related in 8% children who are less than 10 years old. It can occur in up to 40% eyes with RC coloboma. CNV may need anti-VEGF injection. Studies have shown that recurrent retinal detachment can occur in 53% of eyes. 39% of eyes have been shown to have a visual impairment of less than 20 by 400 visual acuity. Other studies shown colobomas to be 70% bilateral, 20% familiar, 3% in blind school children, 10% amongst patients attending a visual disability clinic, and 10% patients for visual handicap certification. Microcornea, types 1 and 2, and intraoperative complications have been associated with poorer visual outcome. The RP Center has taken to apply 3 rows of contiguous laser spots of 400 microns in diameter at the margin outside the arcades, and have found that only in 2 patients out of 323 eyes who underwent prophylactic laser developed rhegmatogenous retinal detachment. So the take-home message is the features of coloboma vary from minimal anatomic evidence to cystic eye formation with commensurate variability in visual function. The extent may vary, and the involvement of disc and fovea may also be variable. An awareness of the types and associations helps in prognostication and timely management of problems associated with this condition. Thank you.
I have one query. So if a child is born with hydrofunder coloboma, we can make out. So what is the earliest age the child should have laser?
Can we have the answer from one of the panelists who is a retina person, Dr. Santosh Mahapatra?
You can, if it is a already macula involving coloboma, there is
In
no
the
need
meanwhile,
for
I'll
laser.
request Dr. Sunil Sunana to take a chair on the other. Please.
If
please,
it is a
please, no,
macula
it's a
involving
protocol
coloboma, there is no need for laser.
There.
You just need to observe it. But if it is a
No, no, no,
macula
yeah,
sparing
part of it.
coloboma, you can do laser as soon as possible when the child becomes eligible to take general anesthesia.
Is there any so much urgency that infant should be put under anesthesia and then
You should not be in a hurry. At least you can wait for a year or so. That can give.
Yeah, Dr. Kashyap, he wants to add something.
We have been doing tackling this kind of a coloboma since long, and I named as a anchoring laser way back in 1994. So we have a vast experience of this. What I feel that the moment you see that is a case of a coloboma, you have to understand whether the macula is involved or not involved. You have to do the laser as early as possible, because the kids are prone for trauma and all that, and the patient can develop retinal detachment after trivial trauma. If if you are doing the anchoring laser, you are surrounding all this coloboma with the laser. You have to you have to make sure that it do not reach the macular arcade. Number 3, if you have not, we have a study also. If you have not done the laser in the posterior pole near the macula, the incidence of retinal detachment is much less. But when the periphery has to be, it has to be included in the laser.
Yeah, thank you,
This is very
Pradeep.
important.
Thank you, Dr.
Thank-
Vibhu.
I'll just have one.
Thank you, Dr.
I
Pradeep.
think, sir, I fully agree with Kashyap, sir. I think it's as early as possible it should be, whether
Yeah.
it is involved or
So
not, because
take home-
handling a detachment is a much more
So
tragic thing to
take home message is that it should be taken up as early as possible. Right, thank you so much.
Thank you,
Yeah.
Dr. Vibhu and Dr. Kashyap, sir.
And our next topic is Aid of Try Today's Best Is It by Dr. S.K. Mitra from Jharkhand.
Good morning, everyone. It is heartening to see almost half of the hall are free. I mean, hall are full with in the early morning of today. So, I'll be talking on some technology. I've got no financial disclosure to make, and I'll talk purely on my personal opinion and personal experiences with evidences. Now, whenever talk about the implantation of something, implantation of any of the lens, we always talk about the spectacle independence. And the common question of the patient asks to a doctor is, "Sir, बाद में चश्मा भी पहनना पड़ेगा?" This is the most common question. So, the lens we are having today, there are limitations, but the newer technologies is coming in the market. So the limitation of the conventional trifocal, I'll be talking about the trifocals. Due to their design properties, all conventional trifocal IOLs inevitably reduce the contrast sensitivity and the generate photic effects. The solution is to blend ADOF with trifocal. The lens combining trifocal technology with ADOF optics provides continuous range of vision from distance to near, uses diffractive rings on the optics similar to the multifocal IOLs. It combines diffractive multifocal and diffractive ADOF technology both. Now the extensive literature search shows that the extended depth of focus versus tropical, trifocal and intraocular lens implantation is a meta-analysis which conclude that the trifocal IOLs improves uncorrected near visual acuity compared to the ADOF IOLs. Uncorrected distance and intermediate visual acuity, halos and glare were not statistically different between both the groups. This again leads to some the search again what to do to reduce the contrast sensitivity, reduce the light energy loss. Now if we look into the conventional trifocals, there are diffractive elements and also called this kinoform, or in simple language it's called the ridges. The trifocals are basically fusion of the bifocals of two different additions like plus 3.5 and 1.75, and these are the heights of ridges you can see. The concept of the kinoform is a type of diffractive optical element often used in lenses that manipulates light waves to achieve specific optical effects. The height of the plates ridges is usually tailored around the wavelength of light milestones to the human eye, which is around 550, it is 546 actually, the nanometers. Now the effect of ridge heights is when the height of the ridge matches the wavelength of light, all the light is directed for the near vision. When the height is half of the wavelength of light, more light is directed to the distant vision, and if there is no ridges, all light is directed for the distant vision. When the ridge height is half the wavelength of light, the energy distribution is 40, 40 and 20. Now these are the apodization, widths and space are the control of powers, and height control the energy split. Now this everybody knows that I'm not going to the details to explain the technologies. But the design of trifocals, different trifocals of comprehensive understanding, these are the trifocals with these are, for example, panoptics, and this is non-apodized, and apodized is gradually tapering actually. Now search results that the clinical outcome of a new diffractive trifocals intraocular lens with enhanced depth of focus. These are the combined ADOF with tri. Now the new trifocal ADOF provides visual improvement of far intermediate near distance with a high level of visual acuity. I'm talking about the 4 years back actually. But this lenses, that time this technology was not there. The new technology, new approaches has come in and the uniform apodization of stretched the super Gaussian profile in non-symmetrical fashion as function of the radial distances. Now see the wave-based design, free of sharp edges of the ring in the lens, and supermoon edges of the optic surface provides no iris shaping, help to reduce halos and scattered light. Phase apodization again enables high balanced light energy distribution to near and intermediate in mesopic, scotopic as well as photopic conditions. See that this lens comprises of the energy distribution and the total loss, and there is no loss, almost the loss is negligible, and in case of the previous, the normal trifocals, the conventional trifocals.
So adopt try gives the light distribution. This the loss of energy is very minimum. We achieve next milestone of energy efficiency of light distribution, resulting in minimum light loss in comparison to the other trifocals. These are the defocus curves. Now there are the highest energy efficiency, crystal clear vision, adaptability of light conditions, perfect energy distribution, and wide MTA peaks. All peaks features wider zones of the diopter, provides excellent extended depth of focus for the enhanced vision. Now these are the there are super smooth edges of optic surface. Phase operation enables high balanced light energy, and the lens has 3 diopters. One is and add of 1.5 and 3. So this is a small clip of one of my patient. This is a high myopic patient. You can see the after cataract development, this patient got medically unfit and he's developed the squint. The biometry shows it needs actually plus 11 diopter of lens. There are 2 cases. One is 11 diopter, one is 9 diopters. So after the phacoemulsification, the simple injector system is Boston-Lomb injector system, like same as Boston-Lomb injector system, with a butterfly cartridge. This is 11 diopter lens. The lens is coming in the blister format packing. So just push vertically, that the lens will free from the package. So place it in the cartridge. It will go through 2.2 millimeter incision site. You can have an wound assisted or you can have direct insertion at 2.4. But it will go through 2.2 incision.
Dr. S.K. Mitra?
Yes. So this is the
yeah.
post-op vision of the patient, post-op pictures, and patient is reading N5, N6. I mean 6, 6, and 6.
Good.
So in conclusion, treat the patient as per the requirements, should not be the biased decision and follow blindly. Patients should be provided with what is the best in today's scenario. Proper planning and execution of surgeon skill is important. For spectacle independence, when the patient asks for spectacle independence, you should think about the adopt try. It's a very good option. Thank you. Thanks for your patience hearing.
A quick comment from the panelists. They want to add anything? Yeah.
I have an objection. What was the age of your patient?
The patient age is 46.
Have you seen the retina? You're putting a trifocal. He's got a long life.
Yeah.
It's got a long life. I do not personally
For the
to it. I don't know what Kashyap will say, but
for the scarcity of time, I could not show those OCTs and fundus pictures.
But could be. But what happens after 10 years to him? He's got a long life. It's a very difficult situation. A high myo especially is prone to retinal disorders. Why are we going to put him in a trifocal?
Before doing such cases, you have to examine the retina thoroughly, and if there is no problem, then we'll go ahead with this.
Yeah.
But they are always prone to certain retinal disorders, and seeing retina in a trifocal and doing work is very difficult sometimes.
But the pre-op check already has done. It's actually I could not this sparsity of time I could not place those things. OCT and retina. Yeah, patients is coming back.
So Dr. Kashyap, I think it's a relative contraindication. Basically, high myops trifocal. It's not an absolute contraindication, but it's a relative contraindication because of the subsequent changes that may take place. Anyway.
Preoperative considerations and examinations are okay, but what we say is in high myopes, it is not only before the surgery if the retina was okay. Exactly. After the surgery, later on things happen because of the changes in the vitreoretinal.
We should avoid, I think, doing in myopes.
So I think that should be.
Okay, if there's any more discussion, we'll discuss it later. We have got limited time. Our topic is surgical caveats in vitreoretinal interface disorder management.
And,
By Dr. Khitish Kumar.
and we have to stick to our time, only 7 minutes, because we
slide
have
is
to
not
wind
getting
up.
displayed.
7 minutes, please.
Yeah, I'll
we have
try
to,
to.
because
A very
we
good
have
morning
to hand
all.
over the.
A very good morning to my esteemed panelists and everyone from Eizoc who is here. So my topic is surgical caveats in vitreoretinal interface disorders management. So I would be basically discussing about the vitreomacular traction syndrome, epiretinal membrane and disorganized retinal inner layers, and lamellar macular hole. I am skipping the macular hole component because itself is a big entity to discuss. So vitreomacular traction syndrome forms a part of the spectrum of diseases with abnormal vitreomacular adhesion. And basically there's an anomalous posterior vitreous detachment accompanied by anatomic distortion of the fovea, and the symptoms could be none. They could be distortion or they could be a reduced visual acuity, and this group classified the vitreomacular interface. Mainly they classified the vitreomacular adhesion, VMT, and the full thickness macular hole. So if we look here, this is a case of a vitreomacular adhesion, and if the area, and we can see that the area of this anomalous detachment is less than 1500 microns, so it becomes a focal one. Again, another example of a focal vitreomacular adhesion. It's a concurrent one because there's a underlying drusen also. Now this is a case of a broad VMTS where the anomalous detachment is more than 1500 microns. So what happens in a vitreomacular traction syndrome, that the foveal anatomy undergoes some distortion, and it can be associated with a epiretinal membrane, and it becomes a broad VMT. And so what if we don't operate vitreomacular traction? So what happens in this study? They showed that 60% would persist, 20% generally resolves. In their study, it resolved in almost 15 months. However, the 12% progressed to full thickness macular hole formation, and 8% had elected for the surgery. So in a case of persistent vitreomacular traction syndrome, the vision may be normal, but with this background, we know that it may progress to a full thickness macular hole. And the same thing we also concluded, we found in our paper that in eyes with full thickness macular hole, the other eye would be having vitreomacular traction in almost 10% of the cases. So now when you're observing a vitreomacular traction, so what happens over the years, you would see these schisis-like spaces forming inside the retina, and eventually it may progress to a full thickness macular hole. And some example of a vitreomacular traction in case of a diabetic, where we can see a neurosensory detachment with a schisis-like spaces forming inside the retina. And coming on to the surgery, so it starts with the trichot-assisted vitrectomy. Then once the trichot goes in, you see that large amount of trichot gets collected at the posterior pole, and then you suck out the excess of the trichot before you start attempting the PVD, else you may touch up the retina. And then you do this gentle lifting in all directions till you have a good purchase and you lift it towards the ora. So that was a case one. And then it is followed by peeling of the ILM so that the puckering doesn't happen. Coming on to the second case, now in this case there was a broad VMTS, and if there's a vitreomacular traction syndrome and you are not able to lift it in one go, then what happens? You may have breaks and in the periphery, so you should always look for breaks, search for the breaks. As in this case, you would see that there were small holes which had formed. In fact, multiple holes had formed all around. And then what you do is you do the laser. So looking for holes in cases of VMTS is very important, just not eating away the vitreous matters, but also securing the retina. And this was a case where, before attempting the PVD, I should have removed the excess trichot and ended up, touching the retina and creating a break near the peripapillary area. And this is another case of a broad VMTS where you see after the PVD has been completed and the VMTS has been removed, there was a peripheral break. Now you see here there's a flap tear which has formed. So you should be very cautious while doing PVD in cases of VMTS, because you may end up having a break in the periphery. Now coming on to the next entity, which is epiretinal membrane with disorganized retinal inner layer. Now if you see here that there's an epiretinal membrane and there's some distortion of the anatomy of the fovea. Now whether there is a drill present or not, for that you have to see that this boundary which is forming between the ganglion cell layer and the inner plexiform layer, and the inner nuclear layer and the outer plexiform layer is distinguishable. If it is distinguishable, then there's no drill. In this case, you see that the boundary is not, the inner boundary is not distinguishable, but the outer boundary is distinguishable. So it's a case of a mild form of drill. If both the boundaries are not distinguishable, then it becomes a severe form of drill, and it may or may not be associated with disorganized ISOS or ellipsoid zone. So it's a severe drill with a disorganized ISOS zone. Now this is a case of a mild drill, the video of which I am going to show. And we had published this paper, and where we always do a double peeling in cases of epiretinal membrane. That is, first you remove the membrane and then you again stain the ILM also and remove it as well. Now in cases of epiretinal membrane, if you see here that you have to keep on doing this pinch and peel and keep on moving in all directions, suddenly you will feel that in one direction it starts getting lifted off easily. And so once complete thorough removal of the epiretinal membrane has been achieved, then you again go in and stain the ILM, and you will see that the ILM is also puckered. So you should always do a double peel in cases of epiretinal membrane. And now you see the underlying ILM was still intact, it was distorted, so just removing the membrane would not have sufficed. So this was the outcome. Now coming on to the last entity, which is the lamellar macular hole. So as we all know that it's an abortive process, it has a defect which is not a full thickness one, and this diagnostic criteria where the lamellar hole has to have a foveal thinning with irregular contour, breaks in the inner layers of the fovea, intraretinal split, and absence of a full thickness defect. Now, Govetto et al. Classified lamellar macular hole into a tractional one and a degenerative one. So in a degenerative lamellar macular hole, you will get a membrane which is called lamellar hole associated epiretinal proliferation, as against a tractional lamellar hole where the epiretinal membrane would be thin and you would have these schisis type of cavities. So the important thing here is to distinguish between a tractional versus a degenerative type of lamellar macular hole, because the approach has to be different.
Dr. Chitej, yeah.
So I'll just conclude. For a degenerative lamellar macular hole, you should not do a double peel, because you may end up in having a full thickness macular hole. Whereas if you have a traction lamellar hole, then removing the epiretinal membrane as well as ILM will suffice. Thank you.
What is your opinion, sir, regarding the use of thermophotolysis?
I have not tried, sir, because that plasmin thing was very expensive, and in cases of VMTS, one may try that.
And what is the incidence of VMT resolving by itself?
So that is what's a 20%.
20. So how much time does it take? I mean,
So
how many months one can wait for that?
So that study showed in the follow-up duration of 15 months, 20% cases had resolved, 60% persisted. Thank you.
Our next speaker is Dr. Santosh Mahapatra from Odisha. He will say, never say no, dealing with the complex retinal detachment.
Good morning, everyone. Thanks for the opportunity. As you know, the retinal detachments where you have this kind of picture with large number of puckers where you cannot see the disc well, grade 4 PVR. Earlier we were saying, no, this cannot be operated. But now with good surgical instruments and techniques and microvitrectomy instruments, we are almost trying to operate most of the retinal detachments. I'll go ahead with just showing few videos. This is a detachment with grade C PVR, but you can see the disc macula well. It has multiple number of tears, but this is a relatively simpler, apart from the number of tears. As you are seeing, multiple number of tears. It can be dealt with complete vitrectomy with putting up a belt buckle, lasering it, and doing a tamponade, which settles the retina at a go. The next case, here you can see the disc is relatively going to be obstructed because the folds of the macula are relatively steep. This is a female which had a long-standing detachment, one-eyed, other eye has become thiacical, and we are just trying to open up the funnel. And you can see here, the vessels beyond the mid-periphery are not seen. The retina is ischemic beyond the mid-periphery. We have tried to do a complete vitrectomy, but still the funnel was not opening. Then we stained it, put some PFCL, gradually the funnel opened, but the posterior pole is still having some membranes, which is not allowing the retina to flatten fully. I'm trying to remove all the membranes from the posterior pole with a finished loop. Now the retina is well settled and it is tamponade is given. This is the pre-op picture. You can see no clear visibility, and this is the post-op picture. The case 3, here we had traction below the retina. There is subretinal gliotic bands, multiple number of subretinal gliotic bands. Initial staining with the tricot was done. Clearing the vitreous in all the sectors was given. Now the bands are not allowing the retina to settle. So multiple retinotomies were done to remove the bands like this in the different quadrants, because it was almost, the bands were touching to each other in a circumferential manner, which was like a napkin ring, and is not allowing the retina to settle down. So this is the pre-op picture in a B scan, and this is the post-op picture. You can see well settled retina. Next one, this is a case of a 58-year-old male who's had hit with a large mango fallen from a tree. But due to his comorbidities, he has uncontrolled blood sugar, he could not be operated, and a long-standing detachment with the disc is barely visible, there is a large tear inferiorly, and there are membranes all over. So after cutting the central vitreous, gradually the membranes were removed. The big large tear inferiorly dithermized. The membranes in the posterior pole was stained, and they are removed, taking help of different instruments, starting from flute to finished loop, and now gradually the retina is getting settled in the posterior pole. So in these cases, the complete removal of vitreous is very important to avoid postoperative recurrence of retinal detachment. But you can should not hesitate to do retinotomies as and when necessary, and remove all membranes to make the retina settle at the end. So this is was the case like this, all crumpled in the posterior pole, and this is the post-op picture. I think this is the last case. This is a young male who had a detachment in the other eye, operated, but has poor vision because of posterior pole pathology. He had a detachment in this eye where nothing could be done apart from 360-degree retinectomy, and the posterior pole only could be settled after the 360 retinotomy, parallel laser being applied to retina all around. So the take-home message is, every complex surgery opens the door to innovations and skill refinement, and it gives you opportunity for your growth. So let us embrace the complexities, and we should not hesitate to operate the complex cases as well, and give a chance vision to all patients. Thank you.
Beautiful videos, but ultimate outcome of the vision, how you have found out?
See, I have operated these cases where you don't have any hope, like other eye, non-seeing eye, yeah. This is the only eye, so you have to operate and at least give a chance. You should not worry about whatever the post-operative vision is going to have. You will have anatomical settlement most of the cases, and definitely some ambulatory vision, which is very, very important for the patient.
Yes, yes. Even if we have a navigational vision, is really good.
Very good.
Thank you. Thank you.
Yeah.
Sir.
Since the patient was highly diabetic,
Which one, sir?
Last case.
Last one, sir. Mango, yeah.
So my question is, if
No.
the patient is highly diabetic,
No, he initially he went away. When he came back, he had uncontrolled diabetic. Again, we had to wait for a month. He had a history of fallen mango 6 months.
my question is, if the patient is highly diabetic,
Can we do it or not?
patient needs immediate cataract
Can we do it or not?
operation, there is going to have some problem, or retinal detachment. If you do not operate, you will have a lot of problem. At what level will you operate at 340 or 400?
Sir, I usually give opportunity even for 200 sugar I operate, but 340 I'll little hesitate.
No, no, you can always do that.
So
You can
what-
put
yeah.
the patient on insulin and we can always do
So,
it.
Try to control.
yeah,
We
yeah.
can, in
So,
emergencies, we can always do it.
Yeah.
exactly, sir.
Diabetologist is there, you put in insulin, now you can always kick it is.
Yes, yes.
You don't have to wait.
For emergency situation, for emergency situation, one can do it, sir. For emergency situation, one can do it.
I
Definitely.
have advised, but
And-
the patient did not come. He thought, let me control the sugar, then I'll come.
Under the
That's
medical
what I wanted to
advice,
convey.
insulin and all, diabetologist, one can definitely, in emergency situation, one should go ahead. I mean,
Yeah, in collaboration with the diabetologist or any.
Thank you so much. Our next speaker is Dr. Lopsang from Arunachal Pradesh. He will talk on basics of IPCL.
this is a very burning topic, and I think this should be taken up by any surgeon. This should be done. This IPCL, ICL, this, yeah. So it's a simple procedure. Only the basics one has to understand, then one can definitely go ahead with it.
Those measurements are important.
Yeah, that is why it's a basics. Surgery is not difficult. Only the measurements and other parameters that has to be taken into account, and he'll take us through. Dr. Lab Singh.
Good morning, Shubh Pravatam, respected chairperson, co-chairpersons, moderator, convener, co-conveners, panelists, esteemed Eizoc members, and dear friends. So I'd be speaking on the basics of IPCL. So IPCL is basically a single piece posterior chamber phakic IOL which can be inserted into the eye through a sub 2.8 mm incision. It has the widest power range starting from plus 15 to minus 30 with a cylinder up to 8 diopters. It is made from hybrid acrylic material to ensure long-term performances. And it's very easy to implant. It can be very easily replicated. And the learning curve also is, I think, very easy. And the patient also has a very fast recovery. And the surgery is less invasive as compared to LASIK and PRK. And the surgery is reversible. And in phakic IOLs, you have enhanced depth of vision because of the proximity to the nodal point of the eye. You have uncompromised contrast sensitivity, zero induced spherical aberration and coma. And you have ability to provide astigmatism remedy and also presbyopic correction. So preoperative assessment, what we need to do, we need to do a objective and subjective refraction. We have to measure the internal AC depth, that is from the endothelial side. If you are doing a conventional ultrasound, then you have to deduct pachymetry from that. And you have to get a good K reading and do a corneal topography. White to white measurement is very important to get a good vault. And white to white should be from the mid-limbus, and it should be done with a digital caliper or with a vernier caliper under high resolution magnification in the microscope. You have to do a IOP measurement preoperatively. If patient is having glaucoma, then I think this surgery is not very indicated. You have to get a detailed anterior and posterior segment examination and also do specular microscopy. So indication of phakic IOL is any person above 18 years of age you can do, and the refraction should be stable for 1 year. Patients who are not suitable for LASIK, if the cornea is very thin or having very flat or very steep K reading, then this surgery is indicated. And myopia, astigmatism, presbyopia or any other ocular pathology. So this surgery is contraindicated in myopia other than axial myopia. And if the endothelial cell is less than 2000 cubic millimeters, then this is contraindicated. If AC depth is less than 2.8, you shouldn't go for phakic IOLs. If there is a history of uveitis, if you have evidences of anterior or posterior synechia, you shouldn't go for phakic IOLs. Glaucoma or IOP higher than 20 mm of mercury, we shouldn't attempt phakic IOLs. And if the patient is having cataract, then always you go for cataract surgery. And diabetes is also contraindicated. So advantages of IPCL over LASIK and PRK is that in phakic IOLs, you don't touch a healthy cornea, whereas in LASIK and PRK, you remove a part of corneal tissue. That contributes to dry eye in cases of LASIK and PRK, whereas dry eye is not very common in IPCL. And this surgery is reversible. If there is any complication, then you can remove it, whereas LASIK and PRK are irreversible. And in cases of thin cornea also, you can go for phakic IOLs, and it gives good UV protection and asphericity. So complications, if you see, if you haven't gone for a adequate size, then there can be descentration. Pupillary block used to be there, very common. Now with the central hole technology, you don't get pupillary block glaucoma. There is pigment dispersion. There can be anterior subcapsular cataract and infection, post-op infection. So this is a surgery. I think video is not very clear, but then yeah, anyway. So we do paracentesis. And I do all the surgeries under hydroimplantation.
Hello.
So while loading the IPCL, it's very important to see for the orientation. The haptic hole should be on the left-hand side, and the two superior holes should be on the superior side, covering, which should be covered with the eyelid. And under hydroimplantation, I am implanting the IOL slowly, phakic IOL slowly. Then you dial the haptic under the iris, and the receding like the haptic. Also, you place it under the iris, and you see for the orientation. Orientation of the IPCL is very, very important. The two superior holes should be on the superior side. I am not using any visco. This is done totally under hydroimplantation. So after getting a good orientation of the IPCL, then you inject pilocarpine, and then whatever little bit of visco, because I put visco in the cartridge, so a little bit of visco you remove, and then you do the stromal hydration, and that's the end of the surgery. So the success of IPCL surgery is that you should have a very, very good patient selection. Your measurements should be accurate. You should do good patient counseling, and your surgical technique should be good. Post-operative observations should also be very, very careful. And with experience, I think this surgery is a very good tool in your cataract and refractive surgery basket. Thank you so much.
Comment from the panelist.
We can put the presentation as phakic IOL instead of this is a very company specific name. I think this we may avoid in future.
Okay, right. So just one quick question. Lot of centers, I mean, lot of cities do not have a specular microscope. So can those people go ahead even without doing any alternative measures so that slit lamp good examination? Can we go ahead with that? No, is it absolute?
But learning curve, I think, as per the surgery, if you see, it's very easy to perform.
So what is the exact clock hour when you have to put the holes?
No, holes basically the orientation of the like phakic IOL should be proper. The preceding haptic, there is a hole. It should be on the left-hand side, and there are two superior holes. So that should be on the superior side while you orient the IOL, phakic IOL.
very good presentation. Actually, he has put it in the without visco. That is a very tricky and it's a very risky affair. Actually, what we are doing with visco.
Yeah.
Visco is a good because you will get more space. And what he has not mentioned, actually, he has shown in the video. The second instrument should guide the lens when it is going in, because the lens might
Rotate
Yeah,
up.
rotate. Yeah, there are chances of rotation because, yeah.
So you have to flip again. So flipping is another problem.
No, flipping should not be done inside. You have to take out the lens and then only insert it again. You cannot flip the lens inside.
And second instrument should be guided.
Lobsang, at the end of the surgery, instead of hydrating the wound, will it be more safer to if you stitch the wound?
No. I think
No,
sir.
It's a very small
stitching may-
incision, so
No,
I don't think so.
but
You
we
need
should
to-
be sure there is no leakage.
Yeah,
no?
that is true. That is true.
But sir, our suggestion is leave a little bit of bubble of air. You know, sometimes the AC leaks, then the lens will not touch your cornea. Just leave a little bit of air. That'll take care. What
Thank you.
That is also.
Sir?
As such, we are putting the lens over the.
Yeah, 2.8.
2.8.
Yeah.
And in the very next day, one day after the surgery, you should see the IOP applied.
Yeah, IOP is very important.
And also
to
the vault,
check.
the vault also has to be seen
Vault
on
also
day
has
one
to be
also.
checked in anti-segment OCT. Yeah. Thank you.
And most of these cases have some amount of astigmatism also. The high marker, they have -2, -1.5.
And,
Yes, thank you.
and Dr. Lobsang, is it necessary to put pilocarpine at the end of the surgery intracameral?
It's not mandatory, but then to get
You
around
put it.
people.
Okay,
and,
right.
yeah.
Okay, right.
I think it's good to put a pilocarpet.
It's good.
An idea that how big is whether it is oversized or not. If it's oversized, then people will never conflict.
The toric version is also available actually.
Yeah, toric version is also available
Okay.
in different, but you don't have to rotate much in the toric version also.
As we have very much paucity of the time, I'll just request our Dr. Joy Gopal Agarwal. No, Dr. Jayanta Das, he is
has
there
got an
next,
instruction
but
course.
he is in another
If
session.
he comes back, then he'll
If
give
he
a
comes in time, he will be there. Yeah, because we have to leave the hall at 11 now, because second persons will be there.
So we have already
Our
calculated
topic
time
is Chat GPT versus Bing AI versus BARD. Recent paradigm shift of application of AI. This time, all artificial intelligence are
all
flourishing.
Yeah.
So let's see.
क्या बोलता है जय गोपाल समझ गए बोल ठीक से बोलो
What I am saying, artificial intelligence is flushing in Eizoc this time. Let's see.
It's flying all over the place. I mean, it's a good thing. This is a new concept. It's a good, yeah, it's a very good thing. Especially what I have seen in glaucoma and all. It's a very good tool. It gives a very good direction. Yeah, diabetic retinopathy, because I am not a retina person. Those people can, but glaucoma I can vouch for. Okay, it is a very good tool. Before it's time, I mean, just like we are using it for a very long time, everybody will agree to the fact that perimetry, we have a stat pack analysis. That is also basically based on artificial intelligence. And a normative data which is being compared to your present data and then giving you as to what is going to happen. Yeah. So.
Okay. Good morning to everybody, my senior colleagues. My topic is recent paradigm shift of application of artificial intelligence in ophthalmology. These are Chat GPT, Bing artificial intelligence, and the BARD. All of you know that artificial intelligence, and it is a very common topic of the day. Since 2015, significant process has been made in the application of artificial intelligence and deep learning in ophthalmology. Deep learning is widely used to detect the wide range of diseases by image recognition using various types of ophthalmic data, such as fundus photographs and OCT. Here, what has been is done in the artificial intelligence. We have collected lakhs of data from the experts, and it is in the actually it is in the cloud form in the space, and artificial intelligence finds the distinct pattern in the randomly cloud of data points already created by large number of cases, and whatever we put the data in that, they just match to that already clouded in the space, that artificial works on the basis of pattern recognition of the stored data. Now, this is just a diagrammatic presentation of how artificial intelligence works. We collect the data pictures and we upload it as pictures and data, and we artificial intelligence, after proper level of investigation, it gives the results very clearly, and it is almost 90 to 95% correct. Now imagine what is now common to the world, where the patient will self-diagnose their medical condition based on the self-reported symptoms and images, and we doctor will manage any medical diseases without prior domain-specific knowledge. Orthopedic surgeon can go for the ophthalmology in this case, and ophthalmologist can go to any other faculties with the help of this. Medical administration work, which is not interesting, such as drafting hospital discharge letters, will be done automatically. All above scenarios, once thought to be idealistic aspiration, are now gradually translating into the realities. It is possible by artificial intelligence, particularly with the recent arrival of ChatGPT. Now, ChatGPT is like Aladdin ka chirag. Now you will order, he will receive the order, and then he will put the answer to you in the written platform. Now ChatGPT is a solution where the ChatGPT is like calling artificial intelligence through human language, just like in Hindi, English, Bengali, and any other language, and artificial intelligence arrive to help you, just like in this picture. So it is a chat box where user interact with the artificial intelligence chat box, not a live agent. How ChatGPT works? ChatGPT is an artificial intelligence tool with deep learning, which understand and interact with the human language. What we ask them, it will in the voice in the artificial intelligence ChatGPT receive it and use the deep learning to complete the process. So we connect ourselves to big data of artificial intelligence cloud through ChatGPT using human language. So ChatGPT or Bing or everything is that it fills the gap between the doctors and the artificial intelligence. We just command and they will reply. In artificial intelligence, previously we have to upload the data and they will send the any message with the pattern recognition. But here we can directly talk to the artificial intelligence through this ChatGPT. Thus, ChatGPT allows to understand and respond to the human expectation when answering the questions. Thus, it can be called generative pre-trained transformer architecture. Generative means it creates new human-like contents. Pre-trained means models contains pre-trained vast amount of multimodal data, and transformer is a question goes through the series of transfer learning and to get the meaningful text data. But due to astounding versatility and function, ChatGPT has permeated in all fields, encompassing the business, entertainment, education, science, legal, and health structure. Now, it is when we started from 2018, and 2019 there's another software has come. In 2020 is another. Now ChatGPT 3.5 come in the November 2022, and the legacy model in 2023 again. But shortly after, the ChatGPT Plus, it is a subscription based. We have to pay that for these services. So now it is widely used in all over the world. Now, another role of artificial intelligence, generative artificial intelligence, and the ChatGPT and ophthalmology. We have patient's perspective, health professional systems, research, and education training. Now, patient perspective, virtual assistant for self-triaging and self-diagnosing. It is a very satisfying to the patient. It helps for the non-medical trained persons and patient for his ophthalmic condition. the virtual therapist for the patient education and counseling. The patient can generate education material from the simplified language, even easy for the layperson. You can ask the artificial intelligence through this chat box and they will answer. And it acts as a therapist for the counseling individuals with chronic eyes diseases and visual impairment that gives mental agony to the patient. Suppose the patient is mentally very hard due to the visual impairment, they can get the advice from through the chat GPT, and chat GPT will answer through the artificial intelligence. Helpful being the multilingual means you can use any language. It can be text to speech. It is when the patient is visually impaired, you can text the message in the speech form and they will answer. Now text to image means video generated platform when the patient will get experience through the video. Now healthcare professional system, here again the synthesized and very diverse source of information of enhanced clinical management by formulating different diagnosis, decision making and treatment plans. Assist the medical administrative tasks also, that is doctoring, discharge, this thing, and processing vast clinical information stored with the electronic health record. It is capable of generating concise, summarized patient record. Okay. Now, for the research work, it gives a wonderful instrument for those who are in the research work, for literature review, abstract manipulation, and debugging codes and the patient requirement. This raises the ethical debate whether the generative artificial intelligence or chat GPT should be recognized as an author in the research article. Based on the ICMJME criteria, the artificial chat GPT should not be included as an author due to lack of ability to approve and final manuscript to take the accountability of the research. Nevertheless, generative artificial intelligence assistant should be acknowledged in the publication. This is the education material. Again, you can ask and they will give the answer. Now, there are many types of chat GPT available in the form. That's in the OpenAI, Microsoft Bing, and the Google's Bard. Now, this is there's some difference. Google Bard is the real-time information has become. If I ask, then Google Bard gives the real-time information. But the chat GPT gives on data up to the 2021. Now, here is the interesting. When you ask the chat GPT, just here I am asking here.
Dr. Agarwal, we have to hand over time.
Just I am asking, what is the recent treatment of uveitis? Just see. नहीं चल रहा है.
Just briefly sum up what you want to say, what you want to convey.
Yes. Now, this will come in this way. Now, whatever knowledge you get, you can get it very easily. So, if we add in the BART platform, if we ask some questions, it will be again. It is not moving actually. Yes.
Soon, yes. Agarwal, hand over karna hai. We have to hand over hall at 11 o'clock sharp.
No.
Take home.
Yes. 1 or 2 minutes?
No. It's already crossed.
Generative artificial intelligence involving revolutionize the ophthalmology. It is, as I have already narrated everything, what is the merit, and now what is the pitfall. It inaccurate response through the great appears great, and it knows it is known as hallucination and fabrication. Thus, we can land it in the false position. And lack of recent knowledge, such as chat GPT model, was trained to October, September 2021, but BART has no limitation. In this way, I am just, it is for the chat GPT, how much it has even come up in throughout the world. As you know, that 31% of doctors throughout the world are using this. Now, the time is coming when the maximum pitfall will overcome, and the chat GPT, along with the Bing artificial intelligence and BARD, will celebrate for the herald of dawn of new era of ophthalmology. We will have the bright future ahead. Thank you.
Thank you. Thank you, Dr. Joygopal Agarwal, to give a very foresight what is coming up. Okay. Anyhow, just a concluding. Thank you, everybody, but we will end up with the concluding remarks from Dr. Sunil Shurana, the convener of the program, who has taken all effort to do the job. Please, Dan.
Thank you, Sarajda. I thank you, our President, Dr. Pranav Ranjan sir, and our co-chairperson, Babulal da and Jayanto da, our Secretary Swaraj da, and all the panelists, all the speakers, co-conveners, and everyone who are present here to make this first ever Eizoc session in annual All India Ophthalmological Conference. And hope everyone has enjoyed the local hospitality, because this all AIOC 2024 is a LOC is conducted by LOC of the East. Is our own conference. We are presenting to the all over the India, not all over India, ever, including 21 international countries. So I hope everyone has enjoyed, and hope to see you all in Eizoc, our Eizoc Mid-Con conference in April 26 and 27. And I am very grateful to our Eizoc Secretariat to give West Bengal the next annual conference in Kalimpong, which will be held in month of October, most probably from 24 to 26 of October in Kalimpong, the majestic hill station of West Bengal, and hope everyone from Eizoc states will join this annual function. Thank you once again. Thank you all.
Thank you so much.
Thank you so much. Thank you.
Over to the next. Oh, Dr. Kashyap is waiting, Junior.
Thank you.